moving on to our third speaker, we have with us Kévin Lasmi. Kévin is an MSF nurse who recently graduated with his Master's in Global Health from Karolinska Institute. He's currently working in neonatology in Sweden and with OCBA's neonatology community of practice. His thesis, which is written in collaboration with the MALARIA Consortium, is the subject of this presentation, which is entitled The Implementation Quality of Seasonal Malaria Chemoprevention, a qualitative study exploring the perspective of caregivers and community distributors in Burkina Faso and Chad. He'll give his presentation in French. Thanks, Kévin.
Bonjour à tous et merci beaucoup pour l'invitation.
Hello everyone, thank you for having invited me. I'm going to present to you a study that has to do with the implementation quality of seasonal malaria chemoprevention. This is a qualitative study that explores the perspectives of community distributors, parents, caregivers in Chad and Burkina Faso. So, trying to move on to the next slide. Oh, here we go. So let me talk about seasonal malaria chemoprevention. It is a malaria prevention strategy that has been implemented since 2012 in the Sahel region. It administers on a monthly basis a preventive treatment against malaria, sulfadoxine, pyrimethamine, and amlodipine once monthly during the rainy season to all children aged 3 to 59 months. So the objective is to increase the treatment and prevention in those children. So SMC prevents 75% of malaria cases, simple cases and serious cases. It is a cost-effective approach, less than $4 per child per season. So this strategy relies on community distributors that are going to go door to door and distribute doses of SP and AQ as a direct administration to the children on day 1, and it's given to the parents who administer the treatment on day 2 and day 3. So MSF was a pioneer in the implementation of SMC since 2012. So back in 2012, SMC was distributed to 33 million beneficiaries in 2020. And nowadays, we have 33 million beneficiaries. You have the map on the screen. Since June 2022, the WHO has extended its recommendations for SMC. Now there are many new geographies that are going to be able to implement it. There are no longer geographical restrictions, so all countries can adopt the strategy now. There are also new preventive approaches that are possible with the RTSS, the malaria vaccine, and we've seen that both approaches are having a positive impact. So with those prevention programs, we've seen that very little research has been carried out in order to assess the quality of those SMC programs. So the Malaria Consortium that implements SMC programs in several sub-Saharan countries has developed quality standards in order to make sure that those programs were consistent and were of good quality. You have a list here on the screen. So planning, supply in SP and Q, supply in material, awareness raising, training, distribution, management, supervision, monitoring, and protection, for example. So those are the pillars of this strategy, and those standards have been used in order to analyze the situations. What we did in this study, we wanted to develop a better understanding of the quality of the implementation of those SMC programs via the lens of community distributors and parents caregivers. And this has been done for Chad and Burkina Faso in 2019. And we are mostly focused on the barriers to good implementation of SMC. As for the method, this was an exploratory qualitative study. We collected secondary data that have been collected during 2 operational research carried out in Chad and Burkina Faso, 16 group discussions in total, so interviews with the community distributors and caregivers. And during the primary analysis of the data for both studies, we realized that many issues had to do with quality, and using new quality standards could be a good thing for this corpus. Now, let's talk about the findings. We have identified 8 subtopics that were associated with quality standards. You have them on the screen: planning, awareness raising, and community engagement, and distribution of SPAQ. Now, let's talk about planning. The rollout schedule. This is something that was quite interesting. It was discussed in Burkina Faso. It was seen as being suboptimal because the rainy season was considered by the participants. They thought that it would start earlier than the actual campaigns. Now, as for the working conditions of community distribution, this was discussed at length. They said that the working conditions were quite harsh because they were experiencing difficulties in being paid, high workload also. But in both geographies, in both contexts, they were quite motivated. They wanted to do their job because they really had the feeling that they were making a positive contribution to the well-being of their community. Now, regarding awareness raising and community engagement, we realized that the acceptance and understanding of SMC was different depending on the context. So in Burkina Faso, it was rather well understood, whereas in Chad, the difference between preventive intervention and cure wasn't necessarily well understood by the parents, the caregivers, and sometimes even by the distributors. As for the side effects, they were discussed at length in both contexts, and people found it difficult to accept the intervention. There were also concerns and rumors, especially in Burkina Faso, where there were some rumors associated with the side effects. Some people were saying that this was on purpose, so that parents would then go to the healthcare centers and would have to pay for that care. In Chad, people were concerned about infertility, so this was one of their main concerns. So also taking into account roles and gender-based responsibilities. We're talking about geographies where mothers and fathers have a very distinct roles. The fathers used to be decision makers. They play a role in the acceptance process, and mothers have an administration role. They would administer the treatment. And we realized that in Chad, the awareness raising of women or the education of women, mothers, wasn't really efficient because they were not necessarily involved in the community distribution level. As for the distribution of both products, well, in both cases, we noticed compliance or adherence issues. I will have to move a bit faster. I apologize for that. I had to prepare some quotes for you. You'll be able to read them afterwards. They're quite interesting indeed. So what are the main topics that were discussed? What adherence? So just as difficult to have under control. Quantitative studies have shown that there is a good adherence, a good compliance. But other studies have shown, especially studies about the pharmacokinetics, have shown that adhesion to SMC could be quite low, only 20% for the Fortune, especially in Niger, for example. So still some work to be done here. So those are some of the main concerns. And people were still worried about side effects. So it's important to engage communities more. Gender also is important. A little research has been done on those gender-related issues. It's important to develop strategies in order to mobilize the people while taking into account the specific roles of each parent. And there's also the retention of community distributors. This is indispensable. Mobile payments nowadays allow us to pay them in a better and faster way. So thank you very much. I'm done. I will be happy to answer any questions. Thank you.
Merci beaucoup, Kévin.
Thank you so much, Kévin. Thank you.
On numbers and coverage, but so important to look at the quality of that coverage. And so a really interesting element of research. We've got a question that's been posted. Someone's asked, I'm wondering if the monthly administration of CPS will not result in another fees for household. If so, is it really cost effective?
Est-ce que vous pouvez répéter? J'ai pas compris, désolé, Johanna.
Can you repeat the question, please? Sorry, I was supposed to ask the question in French. I have forgotten. So I was just wondering whether the monthly administration of a SMC wouldn't be an additional cost for families. Well, SMC is distributed for free. I forgot to mention that. So it's at no cost. This is one of the main principles of SMC. It's not built to families. Okay, so second question. In your view, should we work on improving the compliance, the adherence? How can we do this? Is this key for the program? Well, indeed, this is one of the discussion items of this study. SMC program is a no direct administration for the first dose, and the second and third doses are being administered by the parents' caregivers. And the study really shows that, I mean, there were many uncertainties regarding adherence. Some parents said that they would administer the drug. Others would say that they would keep the medicine for themselves or for neighbors. So I think some work really needs to be done to really improve that compliance in order to monitor things and follow up things better. When we do assessment reports, usually those reports are actually self-reports. And really, there is a bias, there is desirability bias, and I believe that we will have to look into this further. Okay, thank you so much.
Please find Kévin in the break.